Thank you for being here and for seeing me through the whole thing.
You're welcome.
Dedicate this capstone project to Sarah Danielson.
You're very welcome.
For letting me leave early or cry or all of the things I've done in the past 2 years. So I decided to look at waiting room times and patient satisfaction and take a look at our waiting room times. So we'll keep going here. So in 2016, Aurora Healthcare decided to build a surgery center. Some of this background you guys are going to know. And by 2018, the GI department had outgrown our space. We were having 4 doctor days, sometimes seeing up to 30 patients. And we had only 12 pre and post rooms to work with, sometimes 16. At the same time, we added another pain doctor who also used pre and post rooms. So we were just really bottlenecking. As the day would progress, we would bottleneck turning around those pre and post rooms. The procedure rooms could keep up. It really seemed like the physicians could keep up with the patient load, and the staff in the back could keep up, but we just physically would run out of space because people need to wake up. You need to give them time to wake up before you can turn that room around. At the same time, Aurora decides in 2019 to have a growth initiative for the GI department when we already are kind of outgrown in our space. So we started noticing that we just didn't have enough space. And we were concerned about what that was going to do with waiting room times. So when you think about solutions, we sort of brainstormed. We could purchase additional beds that could be used in unused same-day surgery area. They had, probably 8 or 9 eye beds that would take up a room. And so if we couldn't use those in GI procedures. So if we actually bought more beds and stored those on a GI day, we could use some of those rooms. And then you're looking at just literally adding more space. So they're like working with block times, all of that stuff wasn't really an option. We were just really at capacity with stuff. So we had to decide, how can we do this utilizing the resources that we already have? So we started to look at throughput and what could we do to maximize how quickly we were kind of turning the rooms around. Should have my notes. All right, so what is throughput? That was kind of a new word for me. The Fairlex Medical Dictionary describes it as the sum of services provided by a healthcare institution per unit of time. That can mean the number of patients admitted, treated, and discharged in a period of time. It could mean the number of procedures that you perform in a certain period of time. It might be the number of ancillary departments like lab and x-ray that you utilize. It is kind of a manufacturing word when you talk about turning around things and thinking about how you can do things quickly. And again, our focus is to provide safe and kind care. So we can't just look at it from that kind of mechanical word. We also have to be safe, and we have to be kind, and we can't make people feel like they're on an assembly line. Workflows are a set of actions healthcare providers take to accomplish a task. It's fine. And nurses are constantly dealing with their workflows. And because we have critical thinking and problem-solving skills, we're constantly reevaluating the workflows that we use to see if we can find better ways of doing things. But when a situation happens where your normal workflow is challenged, you develop a workaround. And so whether it's a patient census is high and we run out of rooms, our staffing is low, whatever contributes to the problem, we start to kind of, for that day, develop a workaround. The problem is that consistently doing a workaround is going to stress your system, and it's just not, it's not consistent, it's not efficient, and everybody does their workaround differently. So the challenge would be to create or change the workflow for these busy 4-doctor days so that we could increase throughput through the GI department. Our biggest problem was that there was a bottleneck that it would occur because this the admission and discharge nurses just could not turn around those pre and post rooms quick enough. These workarounds are just kind of band-aids. And what might work in one situation might not work in another situation. So really wanting to focus on coming up with a consistent workflow that everybody can utilize at the same time and do it consistently. So a big portion of my paper and the research that I did, let me go back, the numbers, I apologize. The Journal for Outpatient Surgery has deemed that 15 minutes in the waiting room can be used as a benchmark. That's a pretty standard, allowable. Patients do okay with a 15-minute waiting room time. I wanted to find out what our waiting room times were, and then the challenge was what could we do with the resources that we already have without spending any money and have it be nurse-driven. Because this is not what we want. So the plan is to analyze the data, do some research. I did a SWOT analysis when I came up with my topic. I developed a plan. I discussed all this with physicians, administration, with the staff. We had a phone conference with my instructor. Implement the intervention, and then circle back around and look at the data again. Did it change the waiting room times? Did it affect the nurses taking care of the patients? This is why throughput is important. So much of my paper focused the literature review on this, on the link between waiting room times and patient satisfaction scores. And there's just no denying it, that there was a clear link. Even specifically for endoscopic procedures, that people would rate their overall procedural experience, waiting room times did have an impact on that. I wasn't able to really go through and look at patient, due to the time frame of that I had to do this, to look at patient satisfaction scores to measure those before and after the intervention. And so that would be a suggestion for future studies. So this is just a graph of how I did my numbers. I looked at previous 6 months from February. I looked at 4-doctor days and calculated, I went through and I wrote down let's say for the first day is July 11th, and I wrote down every single waiting room time number for that day. Then I would run that through descriptive statistics to get some information. It probably, in hindsight, is not the best way to look at what I wanted to look at, because what I came up with is mean, which is the same thing as an average. I don't know if you can see that or not, but on this day, the mean waiting room time was 21.72, 19, 20, 14, 21, etc. However, if I tried to download, I apologize for doing it like this, but I had to download this at the end. If you look at, went too far. If you look at the waiting room times individually for, let's say, July 24th, we might average and come up with an average of 20 minutes, but there's times like 64 minutes, 84 minutes, a lot of 28, but there's a lot of 1 minute, 5 minute, 3 minute. So when in hindsight, looking at the mean of these times may not have necessarily been a really good indicator. What I would want to say is not ever see a number, because my goal was to have a mean of 15 minutes for a waiting room time. But is that really the best thing to look at? Because if you still have people who are waiting over an hour, 39, 43, 32, 56, 46, and I know that your thought is going to jump to, well, we know what doctor they had. But I brought my original paperwork that I was working on. It's with every provider. It is not because of one provider who maybe goes a little slower than everybody else. It was across the board. It could be a MAC line. It could not be a MAC line. It could be, there was no rhyme or reason as to who had these long wait times. Every one of them had it, scattered throughout. Some of the limitations are, of course, a patient can come at the wrong time. They can show up early because of transportation. There can be maybe an error in documentation of time stamping the times. So those are things to take into consideration too. I didn't actually look at what time a patient was scheduled and what time were they in facility. That would be a little more detailed. So again, I would suggest that if somebody were to do this again and take a look at this again, I would change the goal not to have an average or a mean of 15 minutes. I would say that you need to say nobody in your line is going to be waiting, 84 minutes. I have 120 minutes. I have 90 minutes. I have 70 minutes. It's, but then you mix in a whole bunch of 1s, 2s, and 3s, and it just brings it all averaged. So I'm not sure that was the best number to look at in hindsight. When I put the slideshow together, I was like, this isn't really the measurement tool that I should have used. So I'm going to go back. Oh, too far, sorry. So this was the work I did, though. This was what I did. I came up with these minimum and maximum times of waiting room time, and this was all done through descriptive statistics, like I said. And the end result was that the mean waiting room time was 16.6 minutes. I did a total of 17 days that I looked at, 17 four-doctor days, and we saw an average of 25 patients per day. So this is the consultation room. It was built with the intention that if the provider wanted to have some sort of private conversation with a family based on results or findings, that they could have a private place to have this conversation. However, since we built this place, this room had never been utilized for this purpose, ever. Conversations always happened in the pre and post rooms. Nothing was ever done without the patient being involved. And if it was something serious enough, the doctor would have the patient come back because they're under sedation. And so if it's a really serious result, it's not always a conversation they have the same day. Sometimes they do, but so this room just sat empty, and it's beautiful, and it's lovely, and it's just set up, and it just is empty. I think the one time we used it was when the benefits lady came through and she had a place to sit. It's located smack dab in the middle of our pre and post rooms. So I thought, what if we just took a computer on wheels and put it in there, and we could utilize that room to start the assessment process, the pre-procedure process. I started with a SWOT analysis. to kind of come up with strengths and weaknesses and why this would work. And so on the positive side, the room was available, convenient, and comfortable. All we needed was a computer on wheels, which there was going to be no change in the environment, no added cost anywhere. It would follow our nursing process. It wouldn't change that we are still bringing a patient from the waiting room and doing the admission process. We would timestamp them as pre-procedure, which would decrease the waiting room time, and the patient would feel like they were moving into their process sooner. It also brings them into a quiet, comfortable area with a bathroom closer by, and they're not just out in public because the prep is just makes people uncomfortable. Hoping that we had an opportunity to impact patient satisfaction scores. Again, that was not something I measured. However, would have liked to seen if this intervention changed at all. It would prevent any delays or lags in our procedure lines. Challenges and things that always come up with any project is that the staff may be resistant to change, and that we didn't exactly have a way to document the patient location on our electronic status board. So every time there is a patient is moved and there's a timestamp, an event, their location is also documented. So you know where the patient is at as well as where are they at in the process. With this, we could do the timestamp of them being in pre-procedure. However, we couldn't put them in like the consultation room. So there wasn't a way on the electronic status board to document their location. The nursing staff did come up with a way of on like a cheat sheet that we use, and the physicians also probably refer to that more often, that they would just put a little sticky note that the patient was in the consultation room, and when a pre-procedure room opened, then the patient would be moved there, and then that would be documented. One of the threats to the project was that we had a pain physician who was going to increase his days, and then we were going to have the addition of 4 more GI doctors that we really didn't know how they were going to impact our facility, but we knew that they were going to be in our market for a period of time, and that we might have to accommodate them to some degree. So I wasn't sure how that was going to impact everything, if it was really going to throw things off. Not included in the SWOT analysis, but ended up being a real challenge, was that I took a position halfway through the project, and so I wasn't here. So when most of the time when you do this, you're doing it in your department, and you can be looking at things. But so that was kind of a unique challenge that happened. That was pretty much all that had to happen. We put a computer on wheels in the pre and post, or in the consultation room. And so if all of the pre and post rooms were filled and a nurse was available, and a patient was waiting, she could bring them into the consultation room and at least start asking some of the questions, begin the discharge teaching process, and explain the procedure. There's a lot of talking that happens in our pre-procedure area. And then when a pre-procedure room opened, the patient could easily just walk down the hallway, go in there, and then they can do the whole, getting vitals and changing and getting their IV started. But all that talking could be done and gotten out of the way. So afterwards, I gathered some data. We started this on February 11th. Unfortunately, our patient census dropped dramatically. We hardly had any 4-doctor days because of the physicians had a schedule change. There were vacations involved, and so all of a sudden, when we want to compare, we don't have the same number of patients that we're looking at. However, our waiting room times didn't change, even though we saw less patients. And again, if we went back to where I had the table that had each individual time, you would see that there's still people who were waiting for significant periods of time. that yes, again, the mean still hangs out around at 17 minutes, an average of all of the days put together. But there's still people that are waiting 45 minutes, 60 minutes every day, pretty much every day. So again, doing this project differently, I would look to say that nobody would ever wait more than a certain number of minutes to be brought back. The end result for after the intervention was 17 minutes. Only 9 days were actual 4-doctor days, and those were not necessarily busy 4-doctor days. They were qualified as 4-doctor days, but maybe 2 of the physicians would only have 2 or 3 patients. I did 17 days, and we saw an average of 22 patients per day. So I kind of learned a lot through the process, wishing you had more time. Once you look at your information before and after, I wish I could do another analysis and look at different, like I said, look at different times, not look at averages, but look more at what are actual waiting room times. The SWOT analysis was a huge input. I've never had done one of those before, but it helps you identify things you might come up against. The project was discussed with all our key stakeholders. Everybody was in favor of it. We evaluated the results and actually did not see a change in the mean waiting room times. However, interviews with the nursing staff the ones that I talked to had been using the room and felt that it was benefit to have that space in the event that the bottleneck occurred as we got towards the middle of the day, that people were using it, which that was important. So, what questions do you have about patient satisfaction, GI waiting room times, and the intervention of having the computer on wheels?
Are they going to continue to do it even though it didn't change the waiting room time?
Yep.
Good. Sounds like a great idea.
It's just when you have no space and you see this empty room, you just want to do something. Yeah. And it's located so nicely in our rooms.
That's a good idea.
Did you investigate to see if that could be that room be built in Epic so you could actually put that patient in the room?
I did. And the Epic staff said that they wouldn't do it for a project, but if it was something that the staff was going to continue, that they could build it in as a patient location on our status board. But not for a temporary project or anything else. All right. Well, thank you for being here. I appreciate your time, and that's it.